Today's lecture is about pharmacokinetics and pharmacodynamics of the medications. Pharmacokinetics describes how the body absorbs, distributes, and metabolizes and excretes the drugs. Pharmacodynamics focuses on how drugs interact with their target tissue in the body to produce its effect. Understanding this concept is crucial for dosing, ensuring drug safety, and maximizing therapeutic effect. Key points to remember: pharmacokinetics, the movement of drugs through the body. You can memorize this with the ADME mnemonic. And pharmacodynamics, the interaction of drugs with receptors to produce effects. Pharmacokinetics, first, absorption, movement of the drug into the bloodstream. Distribution, drug spread through the tissue and organs. And metabolism, drug breakdown primarily in the liver. Excretion, drug elimination via kidney or liver. Sample case study: a 65-year-old woman with chronic kidney disease is prescribed digoxin for atrial fibrillation. She presents with confusion, nausea, and blurred vision after 2 weeks of therapy. In this patient with the CKD, excretion of drugs like digoxin is impaired, leading to drug accumulation and toxicity. Adjusting the dose based on renal function is critical to prevent adverse effects and drug toxicity. Sample question I'm going to share with you. A 72-year-old man with heart failure is being treated with digoxin. 2 weeks later, he complains of worsening fatigue, nausea, and visual disturbances. Labs reveal elevated digoxin levels. Which of the following adjustments should be made to his treatment? Correct answer here is going to be reduce the digoxin dose. Digoxin clearance is reduced in patients with renal impairment, necessitating a dose adjustment to avoid toxicity. Absorption and bioavailability. Absorption refers to how a drug enters bloodstream from the site of administration. Bioavailability is the percentage of the administered drug that reaches the systemic circulation in an active form. Oral drugs have varying bioavailabilities due to first-pass metabolism, where IV drugs have 100% bioavailability. Key points to remember: bioavailability, proportion of the drug reaching systemic circulation. First-pass metabolism is the metabolism in the liver before reaching the systemic circulation. This is mainly oral drugs concern. Quick bioavailability of common drugs. Morphine, oral administration gives us 30 to 40% bioavailability. Ibuprofen, oral administration gives us 80% bioavailability. And furosemide, oral administration gives up to 60% bioavailability. Metoprolol, oral administration gives us around 40 and 50% bioavailability. And morphine, if given IV, its bioavailability is 100%. Sample case study: 45-year-old man is started on oral morphine for chronic pain, but reports that it's not relieving his symptoms, as well as when he was receiving IV morphine in the hospital. This highlights the difference in bioavailability between oral and IV routes. Oral morphine undergoes significant first-pass metabolism in the liver, reducing its effective concentration in bloodstream compared to IV administration. Sample clinical vignette question: a 12-year-old girl with a sickle cell anemia switched from IV to oral morphine for pain management during a hospital stay. She complains that her pain is not well controlled as it was with the IV formulation. What is the best explanation for this situation? The correct answer here is oral morphine undergoes first-pass metabolism, reducing its potency. Oral morphine is metabolized in the liver before reaching systemic circulation, decreasing its bioavailability and reducing its effect compared to IV administration. Drug distribution. Distribution refers to how a drug is transported from the bloodstream to tissues and organs. Lipid-soluble drugs can cross cell membranes easily and are distributed widely, while water-soluble drugs tend to stay in the bloodstream. Factors such as blood flow, protein binding, and tissue permeability affect drug distribution. Key points to remember: volume of distribution, theoretical volume in which a drug is distributed, and factors affecting distribution: blood flow, protein binding, and lipid solubility. I'll share the table drug excretion by pathways, renal versus hepatic. Digoxin is excreted renally. Its clearance rate is shown in the table below. Metformin, renally excreted, warfarin is hepatic or biliary excretion, and morphine is renal excretion, as we mentioned above. Sample case study. A 70-year-old man on warfarin develops a deep venous thrombosis and is given gentamicin for a concurrent infection. His physician monitors his INR closely due to the interaction between warfarin and protein-binding drugs. Warfarin is highly protein-bound. When another protein-bound drugs like gentamicin is introduced, it can displace warfarin, increasing the free concentration of warfarin and the risk of bleeding. The clinical vignette questions. A 9-year-old boy with a congenital heart defect is being treated with warfarin. He is prescribed antibiotics for an infection, and shortly afterward, his INR increases significantly. Which of the following best explains these findings? Correct answer here is the antibiotic displaces warfarin from protein binding sites. Many antibiotics can displace warfarin from its protein binding sites, increasing the free fraction of warfarin and elevating the INR and increasing the bleeding risk. Metabolism and drug clearance. Metabolism refers to how the body breaks down drug primarily in the liver through phase 1, oxidation, reduction, and hydrolysis, and phase 2, the conjugation reactions. The cytochrome P450 enzyme system plays a crucial role in drug metabolism. Drug clearance is the process by which drugs are removed from the body, mainly through renal or hepatic excretion. Key points to remember: phase 1 and phase 2 metabolism. Phase 1 modifies drugs. Phase 2 makes them more water soluble for excretion. Cytochrome P450 enzymes, major enzymes responsible for drug metabolism. Drug clearance, renal or hepatic mechanisms eliminate drugs. Sample case study to understand this concept. A 35-year-old woman on oral contraceptive pills for birth control is prescribed rifampin for tuberculosis. She later becomes pregnant despite taking her contraceptive pills consistently. Rifampin induces cytochrome enzymes, that is 3A4, which accelerates the metabolism of oral contraceptives, reducing their effectiveness. This highlights the importance of understanding drug interactions in clinical practice. I'm going to share example of clinical vignette questions. A 58-year-old man with HIV is prescribed rifampin for tuberculosis while on antiretroviral therapy. After 1 month, his viral load increases. What is the most likely explanation for this? Correct answer is rifampin induces cytochrome P3A4 enzyme, reducing antiretroviral levels. Rifampin induces the cytochrome enzymes, which accelerates the metabolism of antiretroviral drugs, reducing their effectiveness and leading to increased viral load. Excretion and elimination. Excretion of the final step of the pharmacokinetics, where drugs are eliminated from the body through the kidneys, urine, or liver through bile. Impaired renal or hepatic function can slow drug clearance, leading to drug accumulation and toxicity. Adjusting doses in patients with kidney or liver disease is essential to prevent adverse effects. Key points to remember: renal excretion, primary route for most drugs. Biliary excretion, some drugs are excreted through the bile. Clearance is the volume of plasma cleared of the drug per unit time. Sample case study to understand the concept. A 60-year-old man with chronic kidney disease is prescribed metformin for type 2 diabetes. After several weeks of therapy, he develops lactic acidosis, rare but serious side effect. Metformin is primarily excreted by the kidneys, and in patients with renal impairment, he develops lactic acidosis. Metformin doses should be reduced or discontinued in patients with reduced renal function. The clinical vignette question. A 75-year-old woman with reduced renal function is prescribed metformin for type 2 diabetes. Several weeks later, she presents with fatigue and lab findings suggestive of lactic acidosis. What is the most appropriate next step? The correct answer is discontinue metformin. In patients with renal impairment, metformin can accumulate and lead to lactic acidosis. Discontinuing metformin is necessary to prevent further complications. This concludes today's short lecture overview. Thanks for watching and see you next time.